So good afternoon, everyone. Thank you for inviting me here. So now we move on to the adolescent stage. So how do we prevent PCOS in an obese prepubertal girl? So all of us know that PCOS is extremely common condition seen across all countries. Comparing to the Western phenotype, which is much milder, we know that in Southeast Asians, what happens is we have more of increased central obesity. So we call this the thin fat phenotype. Two people having the same body mass index, an Indian may have higher visceral fat, they have more belly fat. So because of that, you have more insulin resistance. Due to this, you have higher degree of hirsutism and acne and more of infertility. This leads to lower live birth rates during IVF. So it's a disease across all lifespans. In adolescence, it's actually, like we have discussed earlier, it's a difficult condition to diagnose because there's a lot of overlapping because of the normal hormonal changes of adolescence and puberty and PCOS overlap a lot. So the symptoms of irregular menstrual cycles and acne are quite similar. As we have discussed earlier, the ultrasonographic features are not easy to make out in adolescence. They overlap a lot. Hyperandrogenemia is a classical feature which helps us. Now in the reproductive age, the primary issue moves on to fertility. This is because of the high levels of androgen which affect ovulation, and because of this you have higher rates of hypertension and eclampsia. High risk of endometrial cancer is seen in later years. Now when we move on to menopause, this goes on and you have increased risk of endometrial cancer, ovarian cancer, and a lot of increase in diabetes. We as endocrinologists are facing a tsunami of diabetes right now. So much cases have gone up. So like we discussed earlier, all the risk factors start in utero. Like the Barker hypothesis, there's a lot of CNS programming, epigenetics and genetic variations have a role. Adrenarche occurs earlier. There are lots of factors related to inflammation that have a role. There are a lot of endocrine hormonal disruptors which affect the hormones in the adolescent age. Lack of exercise, poor diet, this leads to hormonal changes. And finally, in adulthood, you have insulin resistance, changes in the ovarian function, and excess of androgen hormones. So if you want to tackle it, you need to tackle it in utero or early on in the adolescence phase. So let's go back to the pathophysiology. So this is a picture way back from NEJM. So it all starts from the insulin resistance, which has three effects. The hyperinsulinemia affects the hypothalamus. At the level of hypothalamus, what happens is the GnRH becomes more pulsatile. This favors LH production over FSH. So if there's more LH at the luteal cells, more testosterone is produced. They bypass the further destruction by the aromatase and they are going into the system. Otherwise, what happens is usually the testosterone with the help of aromatase in the granulosa cell gets converted into estrogen. But because of the high insulin, this cannot occur. Similarly, the high insulin at the level of liver reduces the sex hormone binding globulin. So there's more amount of free androgens in the blood. At the level of the adrenals, again there's a stimulus in production of more of the adrenal androgens. So if you want to tackle something, it has to be this insulin resistance which is causing hyperinsulinemia. So if you talk about insulin resistance, it affects both the ovary and leads to more androgens. It affects the liver and reduces the sex hormone binding globulin, and it increases the pulsatility of the GnRH, which leads to an increased level of LH. So where do we start from prevention? So like we discussed, madam discussed earlier, it all starts in utero. So there's so many genes associated with PCOS. Genes which are involved in epigenetics, genes which are related to the androgen axis, genes related to insulin, genes related to the ovaries and adrenals, but we are yet to pinpoint any specific gene. All of them are just shown some association. So there's no point of talking of prevention of this. There's no data to show that you could tackle these genes. But we have a lot of data coming on to the other parameters. So if you have obesity, you can definitely tackle the diet and the exercise. So there was this good meta-analysis systemic review published last year. And they talk about the ideal diet is a balanced diet, something like the DASH diet, which is balanced. So you should have lots of fruits and vegetables. Again, the vegetables should be low in glycemic index. So if you're talking about vegetables which have high glycemic index, they are your potatoes and your sweet potatoes. So those are the ones that you need to keep out of your plate. All the other vegetables are quite good. You need some amount of protein, calcium, vitamin B12 in your diet. So low fat diet really helps. Omega-3 fatty acids are the good fatty acids. So fatty fish is good. Good source of oil is olive oil, vegetables oil like sunflower, they are really good. Nuts, almonds, walnuts are recommended, legumes. Now the other thing is the point mentioned is whole grain products. All of us invariably tend to eat a lot of refined flour, bread, biscuits, especially in the adolescent age group. Most of their tiffins have biscuits, Maggi noodles. So this has to be counseled that they are not healthy. Alcohol in moderation. There are lots of talk right now about various diets. So the fad diets like intermittent fasting, lot of talk about Dixit diet, ketogenic diet. In the short term, they all give good results, but they are not sustainable. You will find no data over the period of 3 years or 5 years. They give consistent results. All of them always talk about short term. So when you're counseling someone, it's important that you keep a sustainable diet plan. Now coming on to exercise, this is something again very tough to follow. The various guidelines recommend at least 30 to 60 minutes of moderate to vigorous physical activity. So they say around 150 minutes in a week minimum. This should increase exercise that stimulates the muscles and the bone, minimum of 3 to 5 days a week. So at least you get a rest for 2 to 3 days. You need to minimize sedentary lifestyle, minimize screen time. Again, this is huge. After the last 2 years of COVID, the screen time has gone up exponentially. The other is the sitting time. So they say now currently sitting is the new smoking. There's so many adverse effects seen with sitting. So we need to tackle that. All youngsters nowadays have, a Garmin watch or an Apple watch. So in the clinic, you could download those data and see actually how active they are. Now again, the disadvantages are the adherence and a very high rate of cessation. Many of the people join up gyms, but after 3 to 4 months, they give it up. Now let's look at the data. So this is one place where actually I could get some, randomized clinical trial where they looked into the evidence of 6 trials in terms of in children, if you exercise well, what is their benefit in insulin resistance or insulin sensitivity. They analyzed various different parameters like the glucose level after 2 hours or the HOMA insulin resistance parameter or the Matsuda index. All of them consistently showed it improves insulin sensitivity. So there's no doubt that good regular exercise has benefits. There are lots of RCT supporting this. Next is the screen time. So if you see here again in children who are analyzed, this was published from Australia, 2000 children analyzed, more than 3 hours of exercise, of sitting worsens your HOMA IR significantly. So we need to tell them be away from screens, be active. Now other important risk factor for PCOS is obesity. So for obesity, one important thing is you need to check for negative body image and low self-esteem. Like Dr. Pauline was telling us earlier that if that is there, we need to motivate them further and get them back on track. Like we discussed about diet and exercise, they are the pillars of obesity management. There is some role of metformin and the other drugs also. The last option should be bariatric surgery to manage obesity to help in prevent or reverse PCOS. Now let's look at one by one. Sleep health. Again here there are some data. Disturbed sleep affects your energy expenditure. Studies have shown that this could worsen your insulin resistance. It worsens PCOS. Disturbed sleep ameliorates any positive lifestyle changes. Again, Dr. Pauline spoke about this. If you don't sleep well, there's no way next day early morning you'll wake up at 5:30 and go for your morning jog. So it's important that you stress the importance of sleep. The late night studies, late night, partying out, all of this can affect the ability to exercise well. There's a lot of data to show cognitive behavioral therapy would improve the exercise in general population, but it's yet to be studied in adolescents to prevent PCOS. Now the next parameter that we discuss is the endocrine disruptors. So right from the in utero phase, there are lots of endocrine disruptors that affect the prenatal hormonal milieu. They can affect the organogenesis. In childhood, they can cause adrenarche and menarche. Later on in adulthood, they'll end up with PCOS, diabetes, and insulin resistance. But the issue with this is there are so many endocrine disruptors, right from bisphenol A to dioxins, and they're like almost omnipresent. It's there in so many items. It's there in your food storage containers, it's there in the cosmetics, it's there in flame retardants. So we need two things. We need to be aware of this. We need to get someone from the government to look into it and ban all those harmful chemicals to come into the food system. Now, what about drugs? What is the data of metformin? So this is one of the older studies, but this is the only study we could find the role of metformin to prevent PCOS in children. So they looked into a small patient group of 24 girls. This was done in Spain, who had high risk for PCOS. That is, they had low birth weight and they had precocious puberty. They were all hyperinsulinemic and hyperandrogenic, but they were non-obese. Here, when metformin was given for 12 months, they found that in the placebo arm or in the control arm, the insulin sensitivity deteriorated over the next 1 year and the serum androgens levels were higher. But in metformin treated group, both improved. The insulin sensitivity improved and the androgens improved. So they concluded, yes, early metformin therapy does have a role in reducing the risk of PCOS in a high risk group like low birth weight children. In fact, FDA has approved metformin right from the age of 10 years in children who have type 2 diabetes. So that is FDA approved for diabetes. So it can be used. We don't have any data of metformin in obese children to prevent PCOS. I couldn't get any RCT on that. Other drug that works on insulin resistance is pioglitazone. It's an insulin sensitizer. It improves menstrual cycle and ovulation, but the side effects are weight gain. It can rarely be associated with bladder cancer. It can worsen cardiac failure. There are no clinical trials to verify the efficacy or the safety of PCOS prevention in young children. Inositol, as we will be discussing the next 2 days, there's a lot of data in PCOS per se, but no trials have looked at it for prevention of PCOS. Now, there are a couple of interesting molecules. They are called GLP-1 agonists. They work at the level of the incretin system. They stimulate the pancreas, release some insulin, make the body more sensitive to insulin, as well as they reduce the stomach capacity. So you have early satiety with this, and at the level of hypothalamus, it triggers the satiety center, so you don't feel hungry. So liraglutide is improved in type 2 children above the age of 10 years. These molecules reduce your blood sugar, but it also is approved for obesity per se. It is used for obesity treatment. Since 6 months in India, we have semaglutide. That's the first oral preparation. It's a protein, but it comes as an oral tablet that you take once a day. It reduces the appetite, is approved for treatment of diabetes and for obesity. Semaglutide data for children is not there yet. The best for weight loss amongst all drugs is subcutaneous semaglutide. It gives good results for weight loss up to 10 to 15%. It's available subcutaneously once a week. We'll be getting it in India over the next 6 months. But again, if you look at the data for prevention of PCOS, we don't have anything. Now going on to bariatric surgery. This is the last option in terms of persons who are obese for PCOS. It's only for those people who are unable to obtain their goals via lifestyle changes and via medicines. A study published just last month from China included 90 women who are between 18 to 40 who had PCOS, and their BMI was about 27, and they found that the remission over the next 1 year of PCOS was as good as 75% versus 15% in control. So to conclude, to prevent PCOS in an obese prepubertal children, you need to change the lifestyle, make a healthier meal, be active, limit screen time, sleep well, and regularly monitor the BMI. So that's it. Thank you.